Warm welcome also from my side. Greetings from Vienna this evening. I am at Vienna at the moment, the beautiful capital town of Austria. I hope everybody can see my presentation now. Harry, just give me the sign that you can see it.
Yes, everything all right.
Thank you. It's a pleasure to talk about this topic where Harry and me also wrote the CRAFTA statement. You can find it also on our CRAFTA website under statements. And as I'm also very interested in this topic regarding pain education overall in other pain fields, it is really a pleasure for me to talk about pain education for patients with orofacial pain. For the next 30 minutes, we are going to talk about some definitions about what is pain education and what is chronic orofacial pain. But it also is very interesting to see what are the patient's requirements and anticipations regarding education. What do they want to know? Where do they have a lack of knowledge or maybe suffer also regarding their lack of knowledge? We're talking about some components of PNE, pain neuroscience education, and how can CRAFTA benefit you as a therapist, and what benefits does it offer to the patient, to finally come to a summary. When we are talking about orofacial pain, chronic orofacial pain, we are talking about a pain that is persistent, ongoing, or recurring in the face, mouth, or jaw. If you are looking into the international classification of orofacial pain, you will find a huge chapter about dental pain and dental alveolar pain, but it is also very associated or often associated with conditions like TMG, neuropathic pain, and myofascial pain syndromes. When you're talking about neuropathic pain, you probably are aware of pain regarding to the trigeminous nerve or also the glossopharyngeus nerve, which can lead to a painful behavior. The underlying causes can be very multifactorial, involving biological, psychological, and social factors. So this is also one very, very interesting topic for me, or this is why it is a very interesting topic for me, because it is including all those biopsychosocial aspects. But it is a challenge. Yeah, it is a challenge for us as therapists. We have sometimes very complex situations, very long situations. And as you can imagine, pain in the face is leading to high lack of quality of life. Patients often find this pain difficult to grasp and also difficult to communicate. Even if communication is restricted, maybe because of the pain or because of also some motor behavior. And this is why pain education can lead to a better understanding and maybe also more effective coping strategies. So you will come into situations where these patients with chronic orofacial pain not also have big issues with their own situation, but it is also a very big issue for you. What are the patient requirements? What are their expectations? When I remember some years ago when I started with pain education, I had the attitude that everybody and every patient has to know something about pain physiology. And I started to explain pain, like I will talk about it later, and to every patient. It didn't matter for me if they needed it or not. Nowadays, we know that we have to be aware of the requirements and expectations of those who suffer pain. And there is nice literature also where we can see what are those requirements and expectations. One of those requirements is that this restricted pain communication and hopelessness lead to that they suffer from in their quality of life. There is also a big issue regarding the strained doctor or therapist-patient relationship. Another issue is that financial burden and pain-related changes in facial structure occur very often. Nowadays, there is an insufficient understanding of pain mechanisms and maladaptive beliefs in those patients, so that they don't know what is going on. And many doctors and therapists tell their patients, okay, maybe it is a mainly psychological issue. Maybe it's just in your brain. We know that the brain is a very important organ regarding pain experience, but sometimes people just understand, okay, so it's just an imagination. And this is a belief that can lead to more stress and more fear of pain. And another thing is that this fear avoidance in peripheral central sensitization are very important factors in chronicity. So those things lead to ideas what can be included in a sufficient pain neurophysiological education. When we are talking about pain education, you probably are aware of Explain Pain and the Explain Pain books by David Butler and Lorimer Moseley. 2016, this book already was about 10 years old, and this is not a new wave in physiotherapy or manual therapy. Adrian Lau also described this, this wave and this treatment option as pain neuroscience education. It is a therapeutic tool which is highly recommended by several institutions, especially by the International Association for the Study of Pain. The International Association for the Study of Pain even had a global year for pain education, for excellence in pain education in the year 2019, where they tried to inform not only health professions, but also patients with pain neurophysiological components. In their revised curriculum for pain management, it is a major competence for physiotherapists to work with patients in chronic as well in acute pain states. And in the last years, we can see that there is a big shift from a mainly or solely knowledge-based to a competence-based structure, which includes an empathetic way of speaking and listening and a huge bunch of communication skills. So it's not only important that you know how pain and nociception works, but also that you know how to communicate it, that you listen to the requirements we have been talking before, that you listen to the needs and the lack of knowledge that patients have, and also that you are aware of the patient's pain competencies. Many patients know something about pain, and I think it is very dangerous to start to explain pain or to explain the patient's pain to the patient. When we're talking about orofacial pain neuroscience education, we're talking about an educational approach to explain the neurophysiological, not solely, but mainly the neurophysiological mechanisms of orofacial pain. And it is addressing the accompanying symptoms such as depression, a loss of resilience, and also, and this is a very interesting part we are looking at the moment, also body image disorders. As you can imagine, the face is highly represented in the cortex, in your somatosensory and sensomotor cortex. The aim of PNE is to improve the understanding of pain and identify the maladaptive pain mechanisms, like we have been talking before about beliefs and also pain behavior or avoidance behavior. We are using cognitive and behavioral strategies to manage this pain. Here on the right side, you can see a very nice study from the group of Dagsdottir out of 2016, where they were looking at perceptual distortions of the face. Like I said before, you can imagine the face is highly represented, and if there is pain and ongoing pain states, these areas might be distorted even if you don't see it in an objective way. On the right side, you can see the QR code, and if you are quick enough, take your cell phone and check the QR code so you can directly get to this study. Regarding education, we have some quite good evidence at the moment, but there is still, we still need more evidence to go on and provide this therapeutical tool. And there is a good study by Ruth Meise from Germany. She did it on migraine patients, and she compared physiotherapy alone versus physiotherapy and pain neuroscience education. Both groups showed a reduction in headache frequency. In the P&E group, migraine frequency decreased even more, especially in the follow-up. As a conclusion, we can take this study as with the conclusion, as I said, that P&E can contribute to a long-term reduction in migraine-related impairments, which is very, very helpful. And we have the same ideas. By the way, on the right side, you can see again the QR code to check this study. It's free access. In the same way, we can talk about these aspects in chronic unilateral facial pain. But there is not only P&E to be observed, a combination of manual orofacial therapy, P&E, that means education, graded motor imagery, and facial emotional training lead to improvements in pain intensity, depression, and alexithymia. Alexithymia is a behavioral situation where people are not aware of emotions that they can see in other persons and are not able to scrutinize these emotions. Blindness of feelings, it actually means. It is also increasing the quality of life and motivation for therapy, which is also a quite interesting point, that we use education not to treat pain only, but to use it as a tool to get into action, to get into movement, to desensitize a highly sensitized nociceptive and pain system. Another conclusion of this study from Harry Pikatz and a group is that this multimodal approach have the potential to effectively treat chronic facial pain. And I think personally that we need more of this kind of studies that combine several therapeutic tools. Many years we just looked at one tool, which was quite important to see which one is maybe more sufficient than the other. But nowadays we know that it is a combination of therapeutic tools, and education is one part of it, to get a really sustainable result. We know this, by the way, also from very nice studies regarding back pain, where there is actually quite a similar combination of therapeutic modalities like manual therapy, not orofacial then, manual therapy. Also the education that movement is safe, that your pain system is sensitized, and also aspects of graded motor imagery are included in these studies. When we think about possible topics that can be addressed during education, we have here a nice table that shows us those topics and the probable strategies you can work with. One topic you have to address is the pain competencies of the patients, which means we have firstly be aware of how much and what does a patient know about pain overall as a phenomenon, and about his or her pain. A strategy to educate in direction of pain competency is an explanation with metaphors on this individual basis. Yeah, there are many patients, I remember probably there might be many patients where I did, I think, a proper pain education, but this probably did not address their pain competency on an individual basis. Another topic is the pattern mechanisms and behavior. Patients should be aware of, by example, the cyclical pain behavior of migraine, or sensitization mechanisms that explain also their pain behavior. Fear avoidance is another thing that should be addressed. Here we need some kind of cognitive restructuring and education about the course of the illness or disease. Another topic is passive coping. You are probably aware that many patients in pain, in chronic pain especially, tend to have passive coping strategies. Like, okay, you are the one who fixes my problem. I take my pills, I take my anti-neuropathic pain medication, and they are often not aware that active coping strategies like distraction, exercise training, or behavioral adjustment are very, very helpful strategies to get along with the pain. I'm not talking about getting rid of the pain, but getting along with the pain and also have more possibilities in their daily functioning. And as a last topic, we are talking about distorted bodily perception. This is, I think, one of the future topics we have to be aware of. We know many things from other body parts already, and there are many nice studies done in complex regional pain syndrome, in low back pain, in neck pain, and we are aware that the face, as I mentioned before, is highly represented in the sensory-motor and somatosensory cortex. And there are changes not only regarding body scheme, but also in body image. And we have to incorporate embodiment therapies and also graded motor imagery. So what is our CRAFTA approach? Are we able to give you the possibility to work on this? And of course, as a CRAFTA teacher, I have to say yes, but we are really aware and we are developing very nice approaches for you, even in the foundation courses already, but also in the courses, in the ongoing courses later on to get a CRAFTA certified therapist. We have and we are aware of the biopsychosocial approach for craniofacial, craniomandibular, and neuropathic disorders. Even if you just look at the RCTMD classification for temporomandibular joint diseases or disorders, we are very much aware of those two axes, axis 1, axis 2. And I think that both of those axes are represented in our courses. The IISP curriculum already is integrated into the basic courses, also regarding the pain mechanisms. You have a big development of specific treatment techniques and skills regarding the hands-on approach, but it is also very important for us to get a holistic patient understanding as a central goal. So we are not just looking at one part of the face, the joint, the muscles, but we are also very aware of the whole person in front of us. And I think this is a very important attitude if you're working, of course, with patients, but I think this is a very good attitude we have in our CRAFTA group. Another point is the use of the clinical reasoning process for a very proper functional analysis. When I remember my first sessions as a student in the CRAFTA courses, I thought about, oh God, why do we have to look at all those measurements and all those analyses? But it's very important for the patient also to get a proper analysis, a proper examination. This is something we know from the data now, that patients want to be examined. They want to be listened to, but they also want to be examined. A structural assessment is also included, of course, in the clinical reasoning process in CRAFTA, and also an activity and also participation-oriented therapy planning, which means that if you think about participation in patients with chronic or ongoing orofacial pain, including the situation that many of my patients actually say, okay, I don't go to this party because it could be painful again. I could have my facial pain again after 2 hours, and then I have to go home and I'm disappointing my friends and my boyfriend and my girlfriend. And this is something we have to be aware of. And I include these situations on a social behavior as well. What is in it for the patient? Yeah, we have this patient-centered approach and also regarding desensitization. CRAFTA therapists help reduce physiological and psychological sensitization to the unpleasant sensory and emotional experience. And education leads us to desensitize a highly sensitized pain system. There is a very interesting and nice study from Haley Leake from the Australian group out of Lorimer Moseley, and they did a nice survey regarding what do patients want from, or what do they, how do they benefit from patient education, and what are they benefiting from? And they saw, okay, it's good to know that your highly sensitized pain system, they call it like this, can be desensitized through different modalities. Another thing is that our clinical reasoning is essential for accurate diagnosis and treatment strategies. Yeah, to get rid of those terms like it's non-specific. Non-specific is, I think, the best term we have at the moment, but it's very, very unpleasant for the patients. It means we don't know what it is. Yeah, and the more accurate we are with diagnosis and treatment strategies, the better it is. There are many learning moments during therapy promoting a better understanding of pain beliefs, pain behaviors, and coping strategies. And those of you who did already a CRAFTA course are aware of this, of these aspects. Another very important thing, I think, in the CRAFTA courses, or also regarding CRAFTA therapy, if you may name it like this, is the multidisciplinary approach. And I am very happy that I sometimes have different disciplines in the courses, or that I met also different disciplines in the courses I did as a student, like dentists, like psychologists, not really psychologists, but I know some dentists who also work on a psychological basis, and also speech therapists. The craniofacial region is very complex, but it's treatable using this multimodal approach. The therapy integrates cognitive, functional, and behavioral techniques to reduce catastrophizing. As a last point, it's an interdisciplinary collaboration for complex cases. Yeah, these multifactorial or severe psychological dysfunction requires close collaboration with other specialties. So we have to be open-minded also into the direction of psychotherapists, psychological professions, dentists, speech therapists, and so on, to reassure this holistic treatment. In summary, orofacial pain neuroscience education offers a valuable complementary therapy option for chronic orofacial pain. It is an educational and multimodal approach that can improve pain understanding and promote coping strategies. This is something I really want to focus on. It is not a solely used therapy approach. It has to be integrated, or it has to frame our different approaches, including manual therapy, including active and exercise therapy. But it helps us to promote those active strategies, and it also helps us to promote a proper manual therapeutical approach. But actually, we need further research. We need further research to investigate those long-term effects and an optimal use in physiotherapy. That means we have short-term effects. We can see those short-term effects in education. Yeah, we know this from older studies, also from different areas, but we probably need more of these multimodal designed strategy studies. Can we go on with our CRAFTA courses and with this approach? Yes, we have some update CRAFTA courses you can see here. I will get back to these slides a little bit later. But it is also very interesting to look at those orofacial somatosensory distortion assessment and treatment approaches, where I can get back later on. Here you have some literature I used for this talk. If you check the QR code, you can get directly to our statement. And I go back to the summary and hope that there are now some questions that I can answer.
Okay, Bernard, thank you. Thank you very much. Maybe you can share the screen. You can delete the screen if you want. Yeah, so that we see everybody. I saw no at this moment not a question in the chat, but maybe from the audience, are there some questions or remark or something like this? Yeah, please then open your microphone and ask the question. You can also say it in German or another language. We try to translate it as much as possible.
Yeah, Marie-Paul asks about the financial burdens. I meant exactly. Yes, this is out of a study that asked for the probable problems people with chronic orofacial pain have, and those people also mentioned that it is very hard to finance their problem because they need probably most of the time a physiotherapist, a psychologist, and most of the time also a medical profession, doctors, including medication and so on. So it is actually, and this is a problem we can see in many chronic pain situations, and I also say in my courses that it is very hard to finance your chronic pain. And this is a big issue in our field of management of chronic pain. Yeah, we are talking about a multimodal and a multi-professional approach, but you have to be aware how much that costs. And many patients, you know, this is the other way around in thinking of chronic pain issues. Social status and social background is associated with more chronic pain situations. So in German, there is this wording, die Katze beißt sich in den Schwanz, the cat is biting their own tail. It's a problem, a circulate problem. They don't have money and get more chronic pain. But chronic pain leads to more need of money and financial support. So this is a big issue we have to be aware of. Also regarding the social components, if we are talking about a biopsychosocial approach in pain management. Yeah, we're talking about the biological stuff, we're talking about the psychological stuff, but the social components are often not aware in chronic pain situations. And for chronic pain in the facial region, it is also a very big problem because most or many patients have a lot of referrals to dentists. And everybody knows that dentists most of the time are not the most affordable profession. Yeah, so this is a big issue we have to be aware of. The thing, I think it very quickly leads us to a political discussion, a health political discussion. And I'm discussing these issues in Austria many times. But this is something we have to be aware of. If you have chronic pain, you have to find a way to afford it. This is not that easy. And it's a big issue for the patients. This is what is meant with the financial burden.
Okay.
Situations. Yeah.
Good. Thank you, Bernard. Maybe I have a short question about pain management. Is it so? What is your opinion? When do you start with pain management? Is it from the first treatment that you explain everything with biopsychosocial aspects, or is it later on? What is your clinical decision to do this?
Yeah, my clinical decision depends on the subjective and the objective assessment as well. First of all, I think biopsychosocial thinking is an attitude. It's not a model. It's not a treatment way. I think it's an attitude to reflect and to see the person in front of you with all those components in a biological way, in a psychological and social way. If you can see that there are pain beliefs, or that there is pain behavior that leads to avoidance, or also that there are some kind of the patients talk in a way that where I think, okay, this is going in the direction that there are big beliefs that lead to pain to active avoidance. Then I start assessing also with the help of questionnaires to see how I can grade it. And then I start slowly with the offer of a pain neuroscience education. I don't start with the pain neuroscience education in the first session, but it is an offer actually. Yeah. Do you want to hear more about that? And if the patient says, yes, okay, that's interesting because I don't know how it works. I don't know the connection between psychological situations and my pain situation, then I can offer to the patients, okay, I can give you an explanation if you want to. Do you want to hear more about that? And this is the frame for the whole treatment approach.
Okay.
So it is not you have to listen to me and I tell you how it works. It actually is an offer when I hear that there are beliefs, that there are misbeliefs, that there are maybe also situations patients tell me, okay, I think it's just in my imagination. I think it's just my psychological issue. Yeah. And they give themselves up. So if I hear those, for example, those sentences, then I will offer more education. Do you want to know more about that? Okay, let's talk about that.
Okay. I think that's a good point. I think and mostly we get on the courses or somebody from abroad said, "Oh, now you start also by CRAFTA with hands-on, no patient touch anymore."
No,
Yeah,
no.
of course not. It is a combination. Yeah, as you already said, from
Yeah,
hands-on and hands-off.
yeah,
Then you make a clinical decision how
yeah,
many risk factors, contributing factors there are, that you decide to go more deeper in the
yeah,
pain neuroscience
yeah.
education.
And I also have to be aware of how much is sometimes we have the feeling, okay, there is a big psychological issue, there is a big psychosocial
Mm,
background, but I have to be objective. And so this is why and how I want to assess it also. I use some
yeah.
questionnaires with the
Mm,
help of questionnaires and with the talking to the patient. Of course, my reasoning is more, yeah, it's more safe then. It's
yeah.
more assured,
Okay,
actually. Mhm.
maybe we are at this point now. You have low back pain patient and a patient with orofacial pain. Do
Yeah.
you have the experience that did our other patient with other mechanism like behavior, yeah, and emotions than, for instance, chronic low back pain?
Mhm.
And maybe you can say something to the audience. What is maybe the difference, yeah, in the approach by a chronic low back pain patient and an orofacial pain patient?
Mm, a big difference from a neurophysiological point of view is that the orofacial area is represented completely different in the cortex. This is one biological component. It's not, and maybe this is also leading to the different behavior regarding an emotional and also into a
Hmm.
sensory component. So both ways. Yeah, the
Yeah.
face is represented also in highly emotional situation. That doesn't mean that the the low back pain patient is not suffering also in an emotional way. Of course they are, but the representation and the suffering is also maybe connected to this highly representation and these big somatosensory distortions we have in this field.
Hmm.
I think we learned a lot from research in lumbar spine and low back pain, also from complex regional pain syndrome, which is not that highly represented in the population. But I think we learned a lot from these areas, and now we see, okay, the face is even more tending to distortions and to somatosensory changes because of this highly representation. This is also actually our hypothesis at the moment, to
Hmm.
include all the other stuff. And education is always the framework for similar techniques we are using in low back pain or in other musculoskeletal situations. But I think that one point is the neurobiological background also.
Yeah, yeah, I think so.
And
Yeah.
because we
Yeah.
have some research regarding alexithymia in chronic pain patients, but alexithymia is highly represented in chronic facial
Yeah.
pain. Yeah, we have this
Even in
meta-analysis.
migraine, huh?
Yeah, even in migraine,
Yeah, and the
but in
orofacial
chronic
pain,
facial pain
extremely.
even more. Yeah,
Yeah. Yeah, there are more mechanisms behind this
yeah,
than
yeah,
only the pain.
yeah.
Yeah. Okay, good. Thank you, Bernard.
There's a
Um,
question in the chat, I think, Harry.
I look now in the chat.
Mhm.
Wait a moment.
regarding questionnaires, I used the Fear Avoidance and Beliefs questionnaire
Yeah.
with ABQ. And I also used the Graded Chronic Pain Scale, which is even validated for facial pain. Yeah, it's the GCPS, Graded Chronic Pain Scale, Van Korf scale. You can also find it on the Van Korf. I use these scales. And regarding the psychological background, I used the DAS, Depression, Anxiety and Stress Scale, which is also included in the Deutsche Fragebogen, Deutsche Schmerzfragebogen. And the DAS is very helpful because it differentiates between stress, depression, and anxiety, where I can see which is the biggest component in this psychological background. But I have to tell you something in this aspect as well. Always educate why you use those scales. Yeah, if you do not educate your patients and tell them why you use them, patients really, really quick react with an backfire effect. And I remember one patient once, I did a questionnaire regarding somatoform disorders in a patient, and she was clever. Of course, our patients are clever, and she immediately realized that it is a psychological questionnaire. And I did not talk about this questionnaire with her. And again, she said, okay, the next therapist who thinks this pain and my pain behavior is mainly psychological. And then you have a loss of your therapeutical alliance. Yeah? You have a loss in trust again. And if you do those questionnaires, always educate and talk about the questionnaire you're going to do. Yeah, this is very important, I think. Yeah, functional questionnaires are good to use, and also people tend to fill them properly. But psychological questionnaires, the patients realize that.
Mm-hmm.
Patients are aware of that this is a psychological questionnaire now. And if you don't tell them why you're using it, you might have a loss of trust in your work. I don't know, Harry, how is your
Yeah, I think so.
but this is something I even experienced once.
Yeah. So there's some, first it costs a little bit of time to do this. Then you have to explore it. You have to explain it to the patient. And we have always to be aware that we have not, because it is, what David Butler called this incorrupted reasoning. Yeah. So you get unconscious and decision about what the results is of the questionnaire.
Yeah.
And of course, they are good. They have sometimes very good validity also. But still, it influences you in your clinical decisions.
Yeah.
So what you say, I'm totally right. You have to explain the patient, and you have to also the results embedded in what you see during your signs and symptoms you see by the patients. Yeah, absolutely.
Yes. Yeah.
Okay. So I think this would be the last question. We say we do 40 minutes. There are some people who have only the name, their surname, in the chat. So we cannot really verify, also relate which people that are. So it can be that you get not a certificate. So Mirella, Gabriella, Angelica, etc. They have not their family name. So if you don't get a certificate, send your mail and make maybe a screenshot now. So that you get your certificate. Okay. Yeah, but we try to do our best to get you the certificate as soon as possible. Okay, Bernard.
Shall I show the last slides once more regarding the CRAFTA course and?
Yeah, okay. No, I think that was good. So this CRAFTA course is what we said about body distortion. Yeah, we have the update course. I have to say tomorrow is the update case in Holland is full, and in Hamburg is also full. Yeah, yeah.
Vienna.
In Vienna is still some free place, but if you can come to Vienna, it can be that when somebody's ill that you can come in May, but but in the meantime, it is full. And we have also these courses. The introduction course about somatosensory distortion is nearly ready. Yeah, as we will give you also a mail about it. Dit gives an extra reduced price on the app and the My Face training cards. And we do also this introduction course online for 4 hours, and we have this course also in Hamburg. Okay, so thank you very much for your time. Bernard, thank you also for your presentation, and yeah, I think also on the next time, about 4 weeks, on the same time, we have a statement about one of the topics in the CRAFTA education. So thank you very much, and
Thank you.
bye.
All the best.